بسم الله الرحمن الرحيم. كل سنة وحضراتكم طيبين. Hey, it's my pleasure to be with you today to speak about the PFO topic. Why did I choose PFO? As we all know, patent foramen ovale is an obligatory channel during fetal life for oxygenation of the fetus. بس الديبيت اللي عليها بقى ان هو البريفالنس بتاع PFO is in many papers from 20 to 34% of the population. This is a very high prevalence. مش معقول 34% of the population considered patients. في نفس الوقت we are not going to close the PFO in 34% of the global population. There should be very strict indications for PFO closure. Number one, the cryptogenic stroke, which we don't have a clear cause for this stroke. So we have to investigate and exhaust ourselves to exclude atrial fibrillation, atherosclerotic disease, carotid dissection, intracerebral pathology such as hemorrhage or space-occupying lesions. Other indications for PFO closure, decompression illness. This should be considered only in professional divers. Not every diver is going to close his PFO, but if this is his profession and this is his job, of course this is better to close it so as to avoid the gas bubbles formed during the rapid ascent of the divers. Other thing is the pretypnia orthodoxia syndrome, which is a syndrome where we have desaturation during the change of position from recumbency to upright position. In a case series published in 2018 on 54 patients, they showed improvement with the closure of the PFO. What about migraine and aura? Several studies were performed and they did not show any difference in their endpoints between the closure by PFO device or versus sham. To investigate the PFO, we should first do many investigations and we have to exclude other causes. For example, the hypercoagulable state we're going to do is a full CBC with the protein C and the protein S and everything. Paroxysmal atrial fibrillation, we're going to monitor the patient for more than 30 days. We're going to do a transthoracic and transesophageal echo for exclusion of cardiac thrombus, vegetations, tumors, mitral stenosis, or aortic arch, atheroma, and so on. There is a score which is the ROPE score, which means the risk of paroxysmal emboli, which is a tool that stratifies patients with cryptogenic stroke according to the probability of finding a PFO. It depends on two things, the patient's characteristic and the age. The patient characteristic, if he doesn't have hypertension, history of diabetes, history of stroke or TIA, or if he is a non-smoker, then each one is going to take 1 point. If he's having a cortical infarct on imaging, this is another point. The age, as we can see that the age, with decreasing the age, which means the younger the age, the higher the points. Finally, if I have a ROPE score of 1 to 7, this is PFO is unlikely to be the cause for the stroke. If it is between 8 and 10, then it is likely to be the cause. There are several trials done. The old ones, which was the closure, the PC trial, and the early RESPECT trial, they all showed non-significant reduction in primary endpoint. And then other trials were done, the goal-reduced trial, the close trial, the defense PFO, which was in 2018. They showed significant reduction in clinical stroke and when even compared to antiplatelet therapy, and significant reduction in the primary endpoint with the PFO closure. As we can see here, we are having different trials, but we are all interested in the RESPECT trial because in 2004 it started, and in 2012 we had a message not to close the PFO. But with the extended and long-term results, it presented in 2016 showing that there is a significant reduction of the endpoint, and so the FDA approved the Amplatzer PFO occluder with this study. Another study, which was the reduced study, which started in 2009, and then it was published in 2018, and according to this study and its long term, the FDA approved the Cribriform, the Cardioform septal occluder as a PFO device closure. Because of the high variable anatomical morphology of the PFO with respect to the size, tunnel length, redundancy of the septum, thickness of septum secundum, and relation to the neighboring structures, a single device definitely won't be suitable for optimal treatment of all PFOs. We need devices uniquely suited to specific anatomical variants, and this definitely will improve the success rate of the procedure and minimize complications. We are having two PFOs devices approved by the FDA. the Amplatzer PFO occluder, and the Gore cardioform septal occluder. This is a case with a tunnel-shaped PFO, as we can see here, shunting, with a minimal shunt, as we know, and this is while the device is introduced inside, and this is the bubble test done after the procedure, and it should be done immediately to be sure that the defect is closed completely. Along with the FDA approval of the two devices for the PFO closure came a requirement, definitely, for a long-term follow-up through post-approval studies. The current program will assess long-term safety and efficacy of the Amplatzer PFO occluder with two non-randomized studies. The first one, هنكمل اللي بديناها في الأول through a minimum of another 5 years. Another study is a registry for the new patients with cryptogenic stroke undergoing PFO closure with the Amplatzer PFO occluder device in the United States. We anticipate that there is a similar study will be launched for the Gore cardioform septal occluder as well. In Ain Shams University Hospital, we established a protocol with the stroke unit in the neurology department for patients with cryptogenic stroke since 2018. We have investigated since then 47 patients who have closed 7, and we have closed 7 patients with various interatrial septal pathologies, PFO, fenestrated interatrial septum with an interatrial septal aneurysm, ASDs, and so on. Here is one of our patients, a 26-year-old gentleman presented to the ER after a transient ischemia. He had left-sided paresthesia and dysarthria, persisted for 2 hours and improved by the time he reached to the hospital. He had no history, medical history or surgical history. His neurological examination was free, and he was admitted to be under observation for 24 hours and was kept on dual antiplatelets therapy, and the panel investigations were ordered for him. The CT and MRI, bilateral carotid duplex, his labs, ECG, and the transthoracic echo were all normal. His thrombophilia panel was normal. 72 hours Holter ECG did not show any atrial fibrillation. He was discharged on installed salicylic acid. 3 weeks later, he had a similar episode, which lasted for 3 hours, which was longer than the previous one. His MRI showed parietal lobe ischemia. Anticoagulation was then added, and transesophageal echo was done at that time. And as we can see, this is a flap PFO, and this is here with the color, and it's shunting. And we tried by various views to measure the size of the PFO alone and after introduction of the wire. This is by the 3D echo again. As we can see here, while the wire is introduced inside the PFO, and we can see beautifully the size of and the rims of the PFO. We did a balloon interrogation and evaluation of the rims. Not every case we do this, but the evaluation of the rims is very important. And as you can see, this is the balloon and with the indentation and the sizing of the PFO from various views, and this is where the wire is in. And as we can see, while the wire is in, the PFO increased in size. And we had to evaluate the SVC rim, which proved to be more than 12.5 centimeters, so we chose a cribriform of 25 millimeters. As we can see here, this is the cribriform while introduction, and this is by the cath. All the procedure is done under TEE guidance and 3G as well. And here is after the 3G, after the introduction of the left atrial disc of the device. As I mentioned, transesophageal is guiding the whole procedure to maintain that the defect is closed properly. We are not, it is not affecting any of the neighbors, obstructing the neighboral structure, as you can see here. And this is why the deployment of the device. Again, after we finish, the bubble test, which is very important to secure that the defect is closed properly. And this is how it looks by the 3D. Of course, we are not expecting complete closure except after 6 months. What to discharge the patient on? Antiplatelet therapy is required after PFO closure and may be continued indefinitely. Ladies and gentlemen, patient selection is of utmost importance. Patient selection requires thorough assessment and a panel of investigations. There is still debate, but not that much, how to close or not to close, and we have to be in collaboration with other specialties, especially the neurologist and the anesthesiologist. Thank you very much.